This is Urban Health Today. I'm Tamara Thomas, editor-in-chief of Urban Health Today, and I'm speaking with Dr. Cedric Pulliam, an inflammatory bowel disease patient advocate and partner with IBD Social. He's here to share his difficult journey of getting properly diagnosed after being misdiagnosed and going years without adequate treatment. Thank you for speaking with me today.
Thank you so much for having me. I'm really excited to speak with you, share my experience and journey, and unpack some of the issues that we still face within the IBD patient community. So thank you for having me, Tamara.
Yes, absolutely. All right, let's begin. First off, what is your formal diagnosis?
My
Because
formal,
IBD is
yeah,
a catch-all for multiple inflammatory GI diseases, right?
correct. Yeah, I was diagnosed in 2018 with Crohn's disease. So that is my official IBD diagnosis.
Can you share your journey to receiving an accurate diagnosis?
Absolutely. When I started college in 2008, I started having complications, and a lot of it was always stomach issues or, just not being able to, function properly. Like the bathroom utilization was extremely high. It was impacting work, it was impacting school, impacting studying. I mean, I was a freshman in college. So for me, it was quite bizarre and I had no clue what was going on. And so that continued through college. I would go to the hospital. I've had a couple of hospitalizations during college. And in those hospitalizations, a lot of times they would get me on an IV, they would get me maybe a steroid, and then send me out my way and say, watch your diet, consume less alcohol, get more sleep and things of that nature. So it was more so dismissive in a sense of not really taking the complications or why I was coming into the hospital seriously, and just kind of dismissing it as, oh, this is a college student. He eats poorly. He probably drinks and consumes a lot of alcohol. And this is what is happening to him. And so, despite my efforts of trying to kind of vocalize and advocate for myself, it wasn't really helpful then, just because I didn't have a lot of time to be away from school or away from work. And when I was in the hospital, a lot of times it was, give me what I need to get back better and then get me out the way. And that sort of continued for many years, throughout, even after college. And it wasn't until I was overseas and I also got really, really sick. And it was in grad school. And I had to a point where the hospitalization was more than a few days. It was almost a week. And I sat and was like, something is really wrong with my body, but I haven't like zero clue. There was a bit of a language barrier in the hospital I was at. I was actually still in Budapest, Hungary, where I was in grad school,
Mhm.
in 2013, 2012 to 2013. And I said, something has to give. I have to do something. It didn't happen again. And so the thing is, with what I was dealing with, it would almost be like episodic. It wouldn't be like continual where I was like down and out like for a very long period of time. It would be sort of like episodic and periodic in a sense of like 4 to 6, maybe 8 months, and then boom, like another episode, another hospitalization, and sometimes it'll be more than a year. And so that infrequency, I think when it came to a doctor's eye, they would sort of be like, well, this could be just what you're eating or, what you're doing,
For
instead of
stress.
this could be, or stress. And this may not be a chronic issue or whatnot. It's just,
Mm.
we need to change diet. We need to change this. You like, don't consume alcohol anymore. And so I got a lot of that. And in 2017, 2016, 2017, I was also on a work trip. I was got very sick overseas on a work trip, and my boss at the time was like, "This has happened how many times?" And I'm like, "It's been happening since college." And she said, and she's a doctor, and she was like, "You need to really, when you get back home, you need to really get to someone that can actually figure out what's wrong with you because this is weird. This is abnormal. And if this has been happening for so long, there's something more chronic with the pattern, and there's likely something worse wrong with your body. And she was right, because when I returned home after holidays in 2017, I started searching for a new primary doctor, found a new primary doctor, and about the fall of 2017, that primary doctor went through my chart, went through all of my history, and said, "How many of these hospitalizations with your stomach have you had?" And he looked and counted, and there was almost 20. And he said, "This is a chronic problem." Referred me to a GI. This is when I lived in like Tyson's Corner, Virginia. Referred me to someone in Fairfax, Virginia, and automatically, in the early part of 2018, got a colonoscopy, endoscopy. When I woke up from, the anesthesia, they were like, "You have Crohn's disease and we are going to get you on treatment ASAP." And that was literally my process from 2008 to 2018 to really just have continual hospitalizations, have dismissive or just like scripted sort of like diagnosis from a doctor saying you're stressed, or you need to change your diet, or you're consuming too much alcohol, bad eating habits, and things of that nature, and just really dismissive to me as a patient and to me as a person coming in with, you know, stomach issues, chronic pain, and things of that nature. So it was unfortunate, but to be honest, my journey is not unique. It's so many others that unfortunately deal with this same sort of dismissive nature from the healthcare system and from doctors, that kind of just dismiss the patterns and kind of do not provide the optimal care to patients. And it takes a patient to do what I did. And I literally divorced my primary care doctor, found a new one to be able to get optimal care and to get to the right referral to a GI doctor and get a colonoscopy, endoscopy.
So just backtrack a second. So you said,
Mm-hmm.
so this was a 10-year journey. And
Mm-hmm.
at some point you thought to yourself, okay, well, this is probably more than just stress and diet.
Yeah.
Or was it finally the doctor that you were traveling with that prompted you to say, yeah, I've got to make some changes and change my doctor? Or was it like a reinforcement of what you were thinking? Or was it that other doctor that said, hey, but like what was the catalyst, to finally like sort of, spur you to make some changes in your doctor and say, hey, this is a real issue. This is a real problem.
Thank you for that question. And backtracking is important here because a lot of times people will listen to this story or my story or others. And it's like, how in the world did you let this go on for so long? And a lot of times, as the patient versus the doctor, when doctors tell you like nothing's wrong with you, you just need to change your eating habit, you need to change your diet, or lessen or reduce your alcohol consumption, you believe that. And these things become entrenched into your brain that is what's wrong with me. But despite it continuously happening, that's that doctor and patient relationship a lot of times when they have the medical doctor training and degree, and we're just a patient and we believe
Mhm.
what they say and we continue with that. And so thank you for that question, because I wanted to highlight that piece is like, this is how a person can go undiagnosed for 10 years with a chronic illness and think that they're okay, but they're not, because they're not receiving proper diagnosis or treatment. And in my case, it happened after 10 years. But the catalyst there was my boss, who was a doctor at the time, saying, if this has been happening over this long period of time, that's usually patterns of a chronic illness. And
Mm.
her words expressing that to me is when I was like, you're right. And I've worked in healthcare policy for so long. I was working in global HIV at the time. I mean, we were overseas for work in the global HIV response. And so she was telling me, like, I know chronic illness. I mean, this is the area we work in. She was like, you need to get new primary care provider, and you need to get a referral so that someone that has kind of like a gastroenterology that background can like see you and hopefully provide you a diagnosis and a good treatment care journey for yourself. And her words is what really, drove me to, divorce my primary care doctor, find a new one, have one to listen to me that actually took longer than that kind of 15-minute window with a patient to
Mhm.
really understand what was going on and kind of walk through my history, my chart, and all of my hospitalizations and what was going on. He took the time to spend like an hour in that initial meeting and that initial visit to really go through everything and get me appropriate referral. And I was in the GI's office within like a 60-day window. Of course, we know that it takes a bit of time to get in to see someone, but within that 60-day window, I was able to get my colonoscopy endoscopy and get diagnosed.
Well, 60 days versus 10 years, that's it's still relatively quick from realization to diagnosis. So good on you.
Yes.
How does living in a rural area, in a rural community outside of Atlanta impact your access to specialized IBD treatment and resources?
Thank you for that question. In the beginning, I moved into this rural area in Covington, Georgia in 2022. And I was coming from Buckhead, so very, very close to the city of Atlanta, very close to Midtown. And my IBD care was pretty optimal. I will say that it took my fellow patient advocates more recently, actually, just in 2024, to say, push the needle a bit more and find an IBD doctor that is really actively involved, both in the research and also kind of the product and treatment and different treatment options. Make sure that they're really involved in those spaces. And my IBD doctor for a while in Georgia was just very, very basic, very, he's going to make sure I'm good. He's going to make sure that I see him and I get my colonoscopies routinely and I'm on my treatment and things are good, but not beyond that, not like actively beyond that. And so recently I transitioned from seeing my Atlanta-based IBD doctor to someone close in my county, in Newton County in Georgia. And so far, it's been great. My first appointment was virtual because of the holiday time frame. It was just like an intro meeting with the GI doctor and the care team, like the nurse practitioner.
Mhm.
And really, really excited. I'm actually going to be visiting in person the early part of February, but to say the least, I'm happy with this transition to sort of see how this kind of rural IBD treatment journey is going to be, being home and being close in proximity, like 7 minutes from my house
Oh,
to
wow.
the
Good.
actual doctors versus an hour commute to and from Midtown from Covington, Georgia. So it's exciting times. I'm very positive in, the retrospect of things with them thus far, especially hosting a virtual kind of intro to the patient and to the practice was a very, very good positive feedback, at least from my opinion thus
That's
far.
fantastic. Can you speak to the importance of culturally conscious care for Black IBD patients and how that care is sometimes lacking, often lacking?
Absolutely. One of the things around Black IBD patients is my story around being undiagnosed for like a decade and
Mhm.
finally receiving a diagnosis and getting into treatment. That's very common in the Black community. We have to go back to kind of historically looking at IBD as a disease and a diagnosis where it was only seen that a very specific population only could get an IBD illness and not Black folks, not other, culturally represented communities or populations. And that was that was demystified at a point, but that's history when we look at the medical history here. And so when we look at that inequality kind of spans onto what we see now, where a lot of the Black, regardless of their gender, but a lot of the Black IBD patients
Mhm.
sometimes are not taken serious. They don't receive a proper diagnosis in a proper timeline. And when they do receive a diagnosis, a lot of times they're giving the doctors may not give them optimal treatment options. A lot of times they may be given all of the different kind of, I would say, like third line treatments versus the primary optimal treatments, right? Where you have like a multimodal treatment option versus like you know, here's an option that is going to be get you to closer to remission in a timely fashion than
Mhm.
all of these other options. And so we're seeing that, whereas your treatment options that are being provided to some of the Black IBD patients that may not necessarily be the same, discussion when it comes to other races. And additionally, when we look at just the clinical trial research, we know that there's a lack of, recruitment and retention for Black patients in IBD clinical trial research. And so when we look at the data and the results of a clinical trial study for new treatment options, and we look at the fact that it does not have disaggregate data showcasing racial demographics, gender demographics, and things of that nature, we automatically question how is this going to impact me as a Black person? And those questions in the patient community come up a lot. And it's our advocacy to, the companies manufacturing these treatments to say, you have to work on increasing recruitment and retention and clinical trial research for the Black and other racially demographic communities, as well as we need to be able to say this percentage impacted this particular community that way versus others, because that stuff is important for the patient to know whether or not I want to switch, whether or not I want to stay on my current treatment regimen, or if I want to try something new. And these are the conversations that are continuously occurring in the patient community that needs to trickle to both the provider, the manufacturer, as well as the care team communities that we all see. I will say, culturally conscious care has to be the core. It needs to be a part of training, and that's within any facility, any clinic, or any hospital site, whether it's a big department of gastroenterology or if it's just like a small private clinical site. They need their staff, from the front desk attendant all the way to the janitorial staff to the nurses and the NPs and the physicians. All of them need training, and this training cannot just be a one-off. It needs to be continual training to be able to provide and understand that we all have very different makeups of each other, right? So it's sexual orientation and gender identity. And I know this new age is pronoun usage and making sure that you utilize the correct pronoun, asking appropriately, what pronouns do you go by? He, him, or they, them, or whatnot. But also, when it comes to an IBD diagnosis, a lot of times this is where, some GI docs may not be adequately trained to know this is impacting that person in every component of their life. It's impacting their relationships. It can impact their love life, their marriage or relationship, like with a person. All of these things are happening. What are you offering that patient? Are you offering them any psychosocial support or mental health support to kind of walk through and journey through that process? And a lot of times that's not happening. So this is where you really get into culturally conscious care, because when I come to my Southern family that is Black, that is Native American, that really loves cooking and loves, gathering as family, especially during the holiday season, I have to think about what I eat. all of these things of like, what do I not eat and how do I make this appropriate and nice to refuse some food? All of these things people have to think about, and it could be a psychological battle or a mental battle when you're facing your family and your loved ones, but also thinking about your health. And so all of these to say it's packed into the big box of culturally conscious care, but it's important that we learn, we teach, and we reteach the practices of how we actually practice culturally conscious care in our facilities and our healthcare system.
I just want to circle back really quickly because I was
Hmm.
curious about something. Um,
Hmm.
during your journey, I wondered at any point, did any of the clinicians you saw, did any of them ask you how frequently you were having the episodes?
So there were two.
Mm-hmm.
The one overseas in I was in Malta at the time. It was a study abroad in undergrad. And
Mm-hmm.
then the doctor, the doctor that I saw that got me referred in 2017, those are the two clinicians that asked like, how frequent is this occurring with you? Like, and what do you feel? Like they were asking more questions from that initial question, like how frequent is this happening to you? What are you feeling when this episode occurs? And how frequent are you using the bathroom? And is there any other side effects or symptoms that you're seeing when this episode occurs? Those are the sort of questions that both those two specific clinicians asked me in the
Mm-hmm.
visit. Hmm.
Okay, that's interesting. So for all these years, none of these other doctors thought to ask,
No.
has this happened before?
Right.
That's
And I will say in undergrad,
Mhm,
I was in North Carolina and for undergrad, I went to
mhm,
Elon University, and the place that I would see my primary was a clinic. It was the Coronado Clinic. And so I think when it comes to these sort of like more like clinical spaces versus the hospital system versus some private suite sort of style doctor's office. I feel like with the clinic that I was going for the undergrad for 4 years, it's a in and out. Like that 15 minutes is in and out, in and out.
right.
And i
You were
i
also
only say that.
hospitalized. You were
Is
also
that what?
hospitalized. But you were also hospitalized several times.
Right.
This blows my
Exactly.
mind that
It
nothing.
blows my mind too, and it blow. But I think a lot of times we
Mhm.
have to think even when you're hospitalized, and I'm not giving excuses whatsoever because it's
Oh no, this
inexcusable.
is not
But
right. Exactly.
right, it's inexcusable. We both agree on that. But I think a lot of times when now that I do a lot of healthcare systems like administrative and management work, I
Mhm.
see like how ER doctors are so like the traffic is crazy or the different things that occur where a lot of times you can get that one-on-one time, and when you do is really like how are you feeling, what are your vitals, blah blah blah. Okay, next patient. And so that I think is a disservice, right? That we have to pinpoint how do we fix this? What sort of solutions can we look at? Innovations can we look at to solve these sort of issues? Because maybe if they were solved, then I would have had more time when I was checked into the ER and seeing a ER physician, and they could have brought some specialists that could have been on the clock at the time to see me versus maybe that wasn't their specialty or their expertise, and they could have had someone else come in and look at me and ask me questions, and maybe then I could have got a diagnosis. A lot of those scenarios have ran through my head over the years,
Mhm.
but I know that is the issue. That's one of the core issues in a lot of our emergency room departments or emergency departments, for sure.
So where do you see the biggest gaps in IBD education and awareness, especially in underserved communities?
A lot of times, and I love my family to death. Like just over the holidays, spending time with them and just bring me so much joy and happiness. But a
Mhm.
lot of times, I'm speaking specifically the Black community.
Mhm.
And especially a Southern Black community where soul food is the thing. Like this is our jazz. It becomes seafood and soul food and things of that nature. That's what my family's thing, right? But a lot of times we don't receive proper education around what inflammatory bowel disease or Crohn's disease or ulcerative colitis really is. And, I have recalled bad guts, or you got the bad stomach or things of that nature where family members eat and automatically are in the bathroom because they have the bad guts or something like that. And that sort of like that sort of educational mantra, because that's cultural, that's how we grew up, that's how we talk, versus having actual medical education information like provided to us. I had never heard of IBD prior to 2017, 2018. I knew what a gastroenterologist was, but I didn't know what they did, to be quite honest. And that, for me, knowing this for so long, people are like, well, why didn't you research? And why didn't you do this? I'm like, I was living life at the same time too. Like undergrad, grad school, working full time, throughout grad school, traveling, all the things, trying to have a regular life, but also dealing with this. And so, yeah, I probably could have done more research and things like that. But I feel that there's a gap. There is a gap around education around this, around IBD itself, around how to do, optimal IBD care, like options and resources in your local area, no matter where you live. A lot of these things I didn't get privy to until I started in the patient advocacy lane in IBD. And then that's when I started becoming more aware outside of my own lived experience of how in the dark most people really are around educational resources and information, medical information or health information, how to, how to battle with insurance and, no matter what level or type of insurance of trying to get your IBD care, all of these things. I didn't know that there was such a huge, I would say, a huge visual but also like tactful barrier that exists in that space, especially when you look at communities like the Black community or other racial demographic communities that really are not receiving information and knowledge around what IBD is and how it's treated. Knowledge that it's a chronic illness is something for life. It's at the moment, there's no cure, but there's research around that and, what that research looks like and those studies look like and all these different elements. It took me getting into patient advocacy to learn so much more that I had not a clue about when I first got diagnosed. And even prior, I had even more, no clue whatsoever before my diagnosis in 2018.
Hmm. That's understandable. In your work,
Mhm.
have you witnessed any additional layers of bias or misunderstanding in diagnosing or treating LGBTQ plus patients?
Absolutely. I would say, especially the younger, like when they're in their teenage or, pediatric years and they identify within the LGBTQ plus spectrum, a lot of times like, there's just been a huge gap within that psychosocial and mental health support.
Mhm.
I feel that a person that is not an adult, that's a child or a teenager, already once they get a chronic illness diagnosis, is going to go through a lot, because they're still growing, they're still maturing, they're still solidifying as a person and an individual. So when they add that additional layer around, a gender identity, sexual orientation, it gets even more cumbersome of a difficult thing to tackle, right? And so without adequate, proper, I would say whole approach care where you're not just, here's your IBD treatment, here's your next appointment, here's your next scheduled colonoscopy. It goes beyond, let's get you referred to someone that could, speak to some of these other issues. Maybe you do need some therapy. Maybe you do need some psychosocial support. Maybe you need an actual group that you can like unpack issues with the same age group, maybe the same other racial demographics and things like that, or maybe they're also LGBTQ plus identified, or allies, those sort of things. That's when you go beyond but we don't see enough of that, I would say. We don't see enough of kind of like peer network groups for this particular issue in IBD, and we also don't see enough support for the caregivers because, again, I did my journey very solo. I closed myself away from folks when I would go through episodes because it was a me problem. Not everyone's going to be like Cedric. They're going to do their own pathway around how they don't deal with what they're going through. They may have a partner, or they may bring mom and dad or aunt and uncle or godmom or whomever that they feel they want to be a part of that journey. They need resources too, and they need to know how to best support the patient that they're giving care to as well. And I feel that there's a discrepancy and a barrier that exists with information and resources for caregivers within the IBD space as well. To provide, like I mentioned, we have to think around all the drivers, the social drivers of health here. We have to think about, their economic status, their educational status, their, access to food, transportation. How are they getting to and from these appointments? Are they able to afford it? Their employment status, all of these things matter. And when you bring this to another layer where an LGBTQ person is diagnosed with IBD, that could either be those social drivers could be exacerbated or reduced. It just depends on their individual case.
And that's if they're still living at home, because you have a lot
Yep.
of homelessness among LGBTQ plus youth that is another confounder on top of
Yes.
the stressors of having the disease and not
Yep.
having a proper diagnosis. Well, in your view, what practical steps can healthcare providers take to serve diverse IBD patients better?
First, I think it's so vital for providers to seek out opportunities to learn training. There is a lot of opportunities that need to continue that are already started, but also needs to be provided at a more frequent amount throughout the nation and whatnot. But there's trainings that can be brought to your practices, that can be brought to your hospital care systems. And a lot of it has got to be around culturally conscious care or optimal care in a sense of the health equity lens. These sort of things need to occur. They need to become requirements within your practice, within the healthcare system that you work in. And there's ways that we can make this happen. Reach out to patient advocates, reach out to entities like IBD Social Circle. We are really here to help all parts of this, and that's the providers, that's the patient, that's the caregiver communities. It's the holistic pattern, and we need that training to be incorporated and to be a requirement within the systems. Additionally, there has to be bias training, implicit bias training, and things of that nature, because we know how bias can really impact someone's footprint within the healthcare system. And providers are usually the forefront. And if they don't get it right, then that person can be played for the rest of their life. And it's simple as that. And we have to unpack our biases, and that's implicit biases, that's internalized. All these things have to be addressed. Third, I would say have conversations if you're involved in networks or associations and you're going to conferences. Have the difficult conversations of what are we not doing right. Have the conversations around what can we be doing better. Bring in patient advocates to these spaces to help you, your colleagues, members of your associations and networks to really become better doctors and providers to your clients and to your patients and their families. Because again, you are the forefront, your practice, your nurse practitioners, your nurses, your front desk staff, all of these people make an impact on a patient's day when they come into your facility or your office. And these are ways that you really can make the experience better. You can bring more empowerment to your office. I just feel that there's a lot of training needs because a lot of the medical the medical degree training does not include these elements in their curriculum. They leave out this important area. Now, some are trying to, bring this in depending on the, school that you're getting your medical degree at. And also sometimes there's, certificates and things that exist. But the fact that it's not in a core medical degree curriculum at the moment, especially speaking for the American, the US context,
Right.
I feel that you have to go above and beyond to ensure that you as an individual provider get the training, but then you bring this to your practice, you bring this to the board of your healthcare system and say, we really do need this. And here's the different ways we can bring this to the whole practice and to the whole system that we all work in. These are just practical options. But again, make sure whatever you do, whatever journey you all take as a provider within the system or office or clinic, make sure that you go to patient advocates, those with lived experience, to understand what will be the best, next steps or the best way to incorporate these elements into your practice, as well as into your systems that you're working in. But that would be just my suggestions and my feedback. Never lose sight of how insightful and how empowering a patient advocate can be, because we have the lived experience of dealing with the chronic illness every single day, the treatment journey, and all of the obstacles that we face. And we're going to make sure that whatever you provide or whatever you decide to do in your practice or in the healthcare system, that it's going to be an optimum experience for all patient advocates. That's our goal.
What message would you like to, and this is the final question, what message would you like to share with healthcare policymakers who shape
Mm.
coverage and access issues affecting IBD patients?
They're fellow policymakers, because I used to be a former policymaker myself in the healthcare space. Listen to patients when they come advocate on the Hill, or they come advocate at the state level or local levels. Listen to patients, listen to caregivers, work towards understanding the insurance discrepancies that occur. We are being drained of money to be able to just have optimal care on a daily basis and a monthly basis. And listen to these issues, listen to these stories, listen to these long medical bills after insurance, or if a person is uninsured or underinsured, listen to them and work towards a better goal, a more optimal goal for all. And despite it all, I know money is the core and the center, but think about the life and think about the patient and their health. That should be the center of what you do as a health policymaker. That would be my message.
Hmm. Yeah, to your point, all those hospitalizations, I'm sure, cost more over
Hmm.
time than if someone had asked you the right questions to begin with, and got to a diagnosis faster. That's just
Yes,
plain.
especially overseas. They were even more expensive. Yeah. Sometimes not so much, but a couple of them were. But yeah, totally. They were definitely not cheap, and didn't have, like, I mean, I had good healthcare at the time, good insurance. I was still in undergrad, I was still in TRICARE with my military dependent healthcare. But again, despite it all, going to a hospital or ER and things like that, it gets so expensive for
Mm,
anybody.
yeah, yeah. And just think over 10 years how much that costs. Oh my God, it's staggering to think about. Anyway,
Yeah, I've looked at some of those costs. It's steep.
the cost of not asking the right questions.
That
Dr.
part.
Cedric Pulliam, thank you so much for your advocacy work and thank you for sharing your story today. I really appreciate it.
Thank you for having me. I really appreciate it.